Welcome everyone. Today, after a long time, we are going to study a new topic today. We are going to learn today the management of diabetic ketoacidosis, commonly known as DKA, in young children, the BSPED guidelines. I would like to mention here that the BSPED stands for the British Society for Pediatric Endocrinology and Diabetes. In the management of diabetic ketoacidosis, multiple guidelines and protocols have been published. The most commonly followed until recent years was the Milwaukee Protocol, and subsequent to that, BSPED, ISPAD, all of them different societies have published their different guidelines. Today, we are going to learn about the BSPED guidelines of decay management in children and young adults, and later, after some weeks, we are going to learn about the ISPAD guideline, and we are later going to have a comparison between those two. I'd like to point out here that children can die from decay. Diabetic ketoacidosis is a potentially fatal condition which can cause death of children. The most common cause of death usually is cerebral edema, which has 25% mortality. The death occurs more commonly in younger children, those who are newly diagnosed as diabetes mellitus during the presentation of decay, and the death can be unpredictable and sudden. Hypokalemia is a known complication of decay and a known complication of the management of decay also, and it is potentially fatal. Aspiration pneumonia usually happens in children with decay due to low sensorium, low GCS, and can cause death. And inadequate fluid resuscitation is also a potential cause of death in children with decay. So today we are not going to discuss in detail about the pathophysiology of decay and the causes of decay and all that. All that you can get from the textbook also, and that has not changed since the beginning. We are going to focus on the diagnosis and management, mainly the management part. The diagnosis of decay is fairly simple. The letters stand for diabetic ketoacidosis. So basically, we have to confirm a stage of diabetes which has associated ketosis and associated acidosis. So acidosis is defined as a blood pH of less than 7.3 or a plasma bicarbonate of less than 15 millimole per liter. Ketonemia defined by blood beta hydroxybutyrate more than 3 millimole per liter, and blood glucose can be usually high in diabetic ketoacidosis cases, but some cases, especially in cases with known diabetes, previously known or diagnosed diabetes, it can be normal or slightly higher also. But usually in cases who present for the first time as a diabetic ketoacidosis, previously unknown as a case of diabetes, they have fairly significant glucose level. It is important to point here that you have to use a near point or bedside testing method to diagnose and monitor the ketonemia. And if it is not available, urinary ketone levels can be sent for diagnosis of ketonemia or ketonuria, but it is not useful for monitoring, and double plus is considered positive. Now the classification based on severity. The classification based on severity into mild, moderate and severe decay is based on the venous blood pH and the bicarbonate. So as indicated in the diagnosis in the previous slide, acidosis is defined as a pH of less than 7.3. So it is fairly simple. Any pH lying between 7.2 to 7.3 is mild decay. Any pH lying between 7.1 to 7.2 is moderate decay, and any pH less than 7.1 is severe decay. Similarly, plasma bicarbonate less than 15 is defined as acidosis. So 10 to 15 is mild, 5 to 10 is moderate, and any bicarbonate less than 5 is severe. Important to note here that if a patient who has been diagnosed to have diabetic ketoacidosis, that means random blood sugar is high, ketonemia is there, and acidosis is also there, but the patient is clinically alert, not clinically dehydrated, there is no nausea or no vomiting, they do not necessarily always need intravenous fluid. Child can be managed with oral fluids also. And also, if there is hyperosmolarity with sugar more than 600 milligram per deciliter with little or no acidosis and ketones, that means we have diagnosed diabetes with a hyperosmolar state, but there is no ketosis, no acidosis. It is not decay, rather it is hyperosmolar hyperglycemic state, otherwise known as HHS, and the management is completely different, and the residents have to consult an expert for the management of that. So what is the emergency management? The general measures, as in all cases, A, B, C. A stands for airway, B for breathing, and C for circulation. We have to take care of the airway by maintaining positioning, suctioning. If needed, an advanced airway may need to be placed. Breathing, we have to support that by giving 100% oxygen by face mask. And circulation, we have to place an IV cannula. We have to take the necessary samples for the initial blood investigations. We have to put the chest leads and monitor the cardiac pathology or monitor the cardiac function by basically or essentially seeing the T waves, measuring the blood pressure and noticing the heart rate. So now coming to the initial fluid bolus, the most confusing part. For now, you forget all the previous guidelines you know. Focus on the BSPED guideline. What does the BSPED say? So BSPED says that when a patient is presenting with DKA and you have established the diagnosis, you have to assess the patient whether the patient has features of shock or not. So what are the features of shock in a patient with DKA? If the patient has disproportionate tachycardia, if the patient has prolonged central capillary refill or increased CRT, if the peripheral pulses are poor or low volume, and if there is hypotension, but usually it happens late. So if there is disproportionate tachycardia, increased CRT, poor peripheral pulses, then the patient can be called to have shock. But if these features are not there, that means shock is absent. So what do? We have to give a 10 ml per kg NS bolus over 30 minutes. Shock is absent, but still we are giving a low volume slow bolus because all the DKA patients by default have some deficit, so we have to correct that. But the shock is absent, that means the deficit is not as much as in a patient with shock. So if the shock is absent, this 10 ml per kg NS bolus has to be given over 30 minutes. On the other hand, if the patient has any of these features, that means tachycardia, increased CRT, poor peripheral pulses, the patient is called to have shock. So in that case, what we will do? Yes, so here we are giving 10 ml per kg NS bolus over 30 minutes if the shock is absent. But if shock is present, we have to give faster than that. That means we have to give 10 ml per kg normal saline bolus over 15 minutes, slightly faster. And after the end of 15 minutes, we have to consider reassessment of the child if the patient is still in shock. If the patient is still in shock, we have to again repeat the 10 ml per kg normal saline bolus over 15 minutes. Again, after the end of 15 minutes, we have to reassess. Like that, we have to reassess and continue giving boluses up to maximum 4 boluses. That means 40 ml per kg till the patient does not have any signs of shock. That means suppose after the first bolus 10 ml per kg over 15 minutes, the patient has no signs of shock anymore. That means no more further boluses. But suppose if the patient still has shock, we have to give a second bolus. At the end of second bolus, we have to again reassess. If the patient does not have any shock features of shock, we don't have to give any bolus. But if the patient still has features of shock, we have to give another bolus. That means 30 ml per kg total, third bolus. Like that, we have to reassess and keep giving boluses maximum up to 40 ml per kg total. All the boluses have to be over 15 minutes and all the boluses have volume 10 ml per kg. After 4 boluses also, 40 ml per kg also, if the patient still continues to have any features of shock, we have to consider giving inotropes. So this is very important to know. This is the BSPD guideline. We have to assess the features of shock in the patient presenting with DKA. If shock is absent, we have to give bolus at 10 ml per kg over 30 minutes. If the features of shock are present, we have to give a bolus of 10 ml per kg over 15 minutes. So what are the initial investigations that we need to send? We have placed the IV cannula. We have drawn the samples. So what do the samples have to be sent for? Obviously, we have to confirm by blood glucose monitoring. We have to send the samples for serum urea, creatinine and electrolytes, basically sodium, potassium, calcium, phosphorus. We have to send a quantitative CRP because infection is the most common precipitating factor. Infection and dehydration, those are the most common precipitating factors for a patient with diabetic ketoacidosis. So we have to do CRPQ to confirm that. We have to send the blood gases. We have to do the blood gases as soon as possible, preferably venous or capillary. There is no need to puncture an artery to do arterial blood gas because the definition includes venous blood gas parameters. Plasma ketones we have to do, and in their absence we have to do urine ketones. We have to do the HbA1c or glycated hemoglobin to know about the glycemic control over last 3 months. We have to send thyroid function test and celiac screen because associated autoimmune conditions may be there. We have to do a chest x-ray to look for any features of pneumonia which may have precipitated this decay. CSF analysis if needed if we are suspecting meningitis. We have to send a throat swab if we are suspecting a focus of infection there. We have to send a blood culture to localize the infection and localize the organism. We have to do a urinalysis if it is appropriate, if we are thinking urinary tract infection is the precipitating cause, and we have to suspect sepsis strongly if there is fever, hypothermia, hypotension, refractory acidosis and lactic acidosis. We'll come back to this later. So what are the clinical assessment and record keeping? In when the patient of diabetic ketoacidosis comes, we have to maintain our records in a top-notch fashion because keeping records, maintaining appropriate records is the rate limiting step of management of DKA, I can say, because fluid, insulin, everything has to go particularly top-notch manner. Consciousness, we have to record the hourly GCS of the patient, Glasgow Coma Scale, related to the degree of acidosis and cerebral edema, because the more severe the acidosis, the consciousness is more impaired, and the more severe the cerebral edema, the consciousness is more impaired. We have to do the full examination, and signs of cerebral edema, infection and ileus we have to always look for, because as I previously told, hypokalemia is a complication of decay. Hypokalemia is also a complication of management of decay also. So we have to examine every time, and every time we have to look for specifically the signs of cerebral edema, infection which is the precipitating cause, and ileus which is the known complication. So what are the signs of cerebral edema? Headache, irritability, slowing pulse, rising BP, basically Cushing's triad, reducing consciousness, and papilledema. Papilledema is the late sign, but every time we examine the patient, we have to look for these signs and symptoms specifically to diagnose the cerebral edema if it is happening as early as possible, so that we can have a timely intervention. Weigh the child. We have to weigh the child at the point of admission, because the weight will determine the fluid that we are going to give, the insulin that we are going to give. So basically it is the parameter upon which all the things depend. Now coming to the fluid management, the most important part. The total fluid requirement of a child suffering from decay is the combination of the deficit correction and the maintenance fluid. Deficit, all the patients of diabetic ketoacidosis have some deficit in their body. That is the dehydration that is there, that is precipitating or causing the metabolic acidosis here. So we have to correct that deficit, and we have to give the maintenance so as to match the basal metabolism of the patient. So as we do on a daily basis, the maintenance can be calculated by Holiday-Segar formula, but the deficit, forget what you know from the previous guidelines. What the BSPED says that the deficit will depend upon the initial pH, and the deficit has to be replaced over the 48 hours. So what is the initial pH? During drawing the initial sample, blood sample, we have sent for a venous blood gas, if you remember. So how much is the venous blood gas coming? If the venous blood gas is coming between 7.1 to 7.3, that means either it is mild or moderate decay, then we have to assume a 5% deficit. And if the blood pH is coming less than 7.1, that means severe decay, we have to assume a 10% deficit. What do that 5% and 10% mean? I will tell. But if it is important to remember that if the pH is staying between 7.1 to 7.3, it is mild or moderate decay, we have to assume a deficit of 5%. If it is less than 7.1, that means it is severe decay, we have to assume a deficit of 10%. So that will dictate how much deficit we have to correct. And maintenance, we all know Holiday-Segar formula. For the first 10 kg, it is 100 ml per kg. For the next 10 kg, it is 1000 ml plus 50 ml per kg. And any weight beyond 20 kg, we have to give 1500 ml plus 20 ml per kg. Maximum is 75 kg or 97th centile for the age, whichever is lower. So now coming back to what is that 5% 10% deficit means. Each 1% deficit is equal to 10 ml per kg. So 5% deficit means 50 ml per kg, 10% deficit means 100 ml per kg. So basically what we are telling here is that the deficit that has to be corrected over 48 hours in a mild to moderate decay, we have to correct or replace that deficit. How much is the deficit? 50 ml per kg. 50 ml per kg, why? Because 1% is equal to 10 ml, so 5% is equal to 50 ml. Similarly, in a case of severe decay, how much is that deficit? That is 100 ml per kg. Where from that 100 ml came? Because 10% means 100 ml per kg. So this is important to remember. So we have calculated now the total fluid requirement. As before, the total fluid requirement is the deficit plus maintenance. But in the previous slide, we have discussed whether to give a bolus to a child or not. As discussed, all patients with DKA receive a bolus. The only difference is how many boluses they are receiving and over what time they are receiving. If the patient does not have any shock, the patient is receiving a bolus of 10 ml per kg over 30 minutes. If the patient had shock, the patient is receiving 10 ml per kg bolus over 15 minutes. Further boluses are required or not will depend upon the persistence or absence of the signs of shock. So, if the bolus we have given in a patient who had shock, that means the patient had shock, we have given a bolus. That means the patient had more severe fluid deficit. That means that fluid deficit has to be corrected and it need not be subtracted from the requirement because the patient was having shock. So that deficit has to be corrected. So the bolus given for a patient with shock did not be subtracted from the requirement. But if a bolus has been given routinely to a patient without shock, that means the initial criteria that we discussed, that if a patient does not have shock also, we'll give a bolus of 10 ml per kg over 30 minutes. That deficit correction we have to calculate as part of this. That means this has to be subtracted from this while calculating the requirement. We'll clarify this further while we'll discuss some examples. So coming to this example 1, a 6-year-old 20 kg child with pH of 7.15 and no shock. Assume that this is a case of DKA. These are the parameters. So we have to calculate now the requirement of the fluid, total fluid requirement of the child. So first, no shock. That means you will give bolus or not. Patient does not have any shock. That means the 10 ml per kg NS bolus over 30 minutes has to be given routinely. So a bolus has to be given. How much? 10 ml per kg means 200 ml NS bolus over 30 minutes. Now coming to the requirement, deficit and maintenance. So what is the deficit? How much is the deficit? The deficit depends upon the initial pH. So initial pH was 7.15. 7.15 means this is a moderate decay. Moderate decay means how much deficit you are assuming? 5% deficit you are assuming. How much is 5%? 1% is 10 ml per kg. So 5% is 50 ml per kg. So how much is the deficit? 50 ml per kg means 50 ml into 20 kg is 1000 ml. As the patient did not have any shock, that means the initial bolus given, 200 ml NS bolus given, has to be included as part of this deficit correction. That means now this has to be subtracted from that. So 200 ml bolus has to be subtracted from the 1000 ml coming to 800 ml. This deficit correction has to be given over 48 hours. That means 800 ml over 48 hours means it is coming around 17 ml per hour. So the deficit correction has to run at 17 ml per hour for 48 hours. This is the deficit. Maintenance is easy as part of our daily practice by the Hollier-Segar formula. This is a 20 kg child. So for the first 10 kg it is 100 ml per kg, that means 1000 ml. For the next 10 kg it is 50 ml per kg, that means 500 ml. That means total 1500 ml per 24 hours. That means the rate is coming at 62 ml per hour. But this also has to go on for 48 hours or whatever period the patient requires IV fluid. So what is the total rate? 62 ml per hour plus 17 ml per hour. That means 79 ml per hour the fluid has to run, which is the total requirement of the fluid of this case. Now example 2. So we have discussed on example 1. Now take out your pen and paper, pause this slide, take a moment to calculate the fluid requirement. See if you can calculate the fluid requirement in this case or not. So I hope you have calculated the fluid requirement up to this point of time. This is a 14-year-old weighing 60 kg with pH of 6.9 with shock. That means first let's decide upon the initial bolus. The patient has features of shock. That means how much bolus we have to give? We have to give a bolus of 10 ml per kg normal saline over 15 minutes and we have to reassess. So assuming that we have to reassess after the bolus and the patient has feature correction of features of shock. That means initially we have given a bolus of 600 ml, 600 ml over 15 minutes. At the end of 15 minutes, we have to start the fluid according to the fluid requirement. So how much is the fluid requirement? Let's calculate the deficit. The deficit depends upon the initial blood pH. The initial blood pH is 6.9. 6.9 means severe decay. So how much deficit we are assuming in a severe decay? 10% deficit. How much is 10%? 1% is 10 ml per kg, 10% is 100 ml per kg. So that means 10% is 100 ml per kg, 100 ml into 60 kg is 6000 ml. But as the patient had shock, this bolus need not be subtracted. That means this 6000 ml we have to give over 48 hours. That means the rate is coming at 125 ml per hour over 48 hours, or 125 ml per hour for 48 hours the deficit has to run. And the maintenance is holiday figure. That means for first 10 kg it is 100 ml per kg, that means 1000. Next 10 kg it is 50 ml per kg, that means 500. Next 40 kg 20 ml per kg for every kg, 20 ml into 40, that means 800 ml. 1500 plus 800 means 2300. So 2300 ml over 24 hours, that means 96 ml per hour. But this also has to go on till the point of time the deficit corrects. So 96 ml per hour, this is 125 ml per hour. The total requirement is 96 plus 125, that means 221 ml per hour is the total fluid rate or total fluid requirement of this patient which has to run. Understood? Next, coming to the next slide. What is the type of fluid? This requirement of fluid, we have calculated the amount, but what is the type of fluid or what is the IV fluid that we give? According to the BSPED guideline, it is normal saline, not N by 2 as before, or not half normal saline. It is normal saline, that is 0.9% with added potassium chloride at 40 millimole per liter. It is very important to note. All patients with diabetic ketoacidosis, while being managed, have to be given 40 millimole per liter injection potassium chloride in their fluid, because as previously told, hypokalemia is a complication of DKA and hypokalemia is a complication of management of DKA also. That means all patients have a total body deficit of potassium. If we don't correct potassium deficit in this child, patient will have severe hypokalemia, refractory hypokalemia, which is one of the causes of death in a child with DKA. So 40 millimole per liter means we have to add 10 ml in every 500 ml NS bag. So do not give oral fluid until receiving IV fluid for DKA and ketosis has not resolved or nausea vomiting still there. That means for how long this IV fluid has to go? This IV fluid has to go till the patient is able to take orally, till the ketosis and acidosis have corrected, and till the patient's nausea and vomiting has resolved. That means basically the vital parameters, the complications, the blood gas parameters all have normalized. The patient has a normal GCS and the patient is able to tolerate orally. Till that point of time, this IV fluid correction has to be given, and at that point of time when the patient is able to do all that, we have to stop the IV fluid and we have to switch to oral fluid. And sometimes due to severe hypokalemia there is gastroparesis also. In that case, patient can have severe nausea, vomiting and gastroesophageal reflux also. So in those cases it is important to place a nasogastric tube to do recurrent aspirations or prevent the vomiting. When oral fluids are added before end of 48 hours, we have to reduce IV fluid accordingly, because the IV fluid has to go on, or the deficit correction has to be done over 48 hours. That means till the point of time this deficit correction is going on, ideally we should not give oral fluid. But if the patient is able to do all this and we are deciding to start oral fluid, we have to reduce the IV fluid accordingly and add equal amount of oral fluid. So coming to potassium, all the fluids except the initial normal saline bolus contains at least 40 millimole per liter of injection potassium chloride. So how do we add 40 millimole in every liter of potassium in every liter of fluid? 1 ml of injection potassium chloride contains 2 millimoles of potassium chloride. That means for 40 millimole we need 20 ml. 20 ml in every liter means 10 ml in every 500 ml. That means while preparing the IV fluid as per the requirement, we have to add 10 ml of injection potassium chloride in every 500 ml fluid bag. There is only one exception to this: if the patient has an evidence of renal failure, because if the patient has renal failure, then the kidneys will not be able to excrete the excess potassium and the potassium will build up in the body. So what are the steps? We have to check the initial serum potassium in every patient who has diabetic ketoacidosis. We may get one of the three results. First is the potassium might be completely normal, that means 3 to 5.5 millimole per liter might be the potassium range. In that case, we start potassium right away. Injection potassium chloride 40 millimole per liter. Second scenario is the potassium might be slightly high, more than 5.5 millimoles per liter. So what is the concern here? The actual concern here is that with treatment of DKA, potassium is expected to fall. But if the patient has potassium which is already high, and suppose the patient has renal failure, then the patient might not be able to excrete this excess amount of potassium that is being given to the patient. So we have to establish that there is no renal failure in this patient. How do we establish that? So we have to think in line that you have to start the potassium chloride after the child has passed urine, or the child has history of recent passage of urine, or after the potassium has fallen to less than 5.5 millimole per liter. That means by any way we have to get a history that, or get a finding that the patient is not having any renal failure. Third scenario is less than 3 millimole per liter. So patient has severe hypokalemia or hypokalemia, but with treatment of diabetic ketoacidosis, potassium is expected to fall even more. That means if this patient has less than 3 millimole per liter potassium, and if we start insulin, the potassium may fall even more. And hypokalemia is one of the causes of death in a case of diabetic ketoacidosis. So, preferably in this scenario, we do not start insulin infusion until the potassium is more than 3 millimole per liter, and we have to administer high dose of injection potassium chloride by a central line so that the potassium rises to more than 3 millimole per liter before we can start the insulin infusion. Coming to IV insulin, which is the drug of choice for diabetic ketoacidosis actually, and according to BSPED, we have to start IV insulin 1 to 2 hours after starting the IV fluid therapy. Previously, according to some guidelines, we used to start IV insulin right away, but according to BSPED, we start 1 to 2 hours after starting the IV fluid therapy, and the dose range is 0.05 to zero point 0.1 unit per kg per hour. That is the dose range. In cases of severe decay or a patient who is an adolescent having a diabetic ketoacidosis, we have to start with a higher dose, that is zero point 0.1 unit per kg per hour. In all the other cases, we may preferably start at 0.05 unit per kg per hour. Why this lower limit is preferred in other cases and higher limit is preferred in these cases? Because these cases are more severe. Adolescent decay usually is more severe, and severe decay, so we have to start at a higher range. In all the other cases, a comparative study has been done comparing starting insulin at zero point 0.1 unit and starting insulin at 0.05 unit, and it has been seen that starting at 0.05 unit per kg per hour decreases the incidence of hypoglycemia, which is one of the complications of giving IV insulin. So that's why it has been recommended that in severe decay and adolescent decay, we start at zero point 0.1 unit per kg per hour. In all the other cases, we start at 0.105 unit per kg per hour. But there is no rule of thumb as such. You have to use your clinical judgment and think what is best for the patient, and depending upon your past history or experience. For those patients who are on CSII means continuous subcutaneous insulin infusion, we have to stop the pump before starting IV insulin, because if we don't stop the pump before, the IV insulin that we are giving and the pump insulin that is already there in the patient, those will add together and will lead to higher incidence of hypoglycemia in the patient. And for those patients who are known cases of diabetes mellitus and are on a regimen known as basal bolus regimen, they used to take a long acting insulin dose at night time. It is recommended that we have to continue that long acting insulin same at the same time throughout the decay management, because it leads to earlier resolution of the diabetic ketoacidosis. So how to prepare the insulin infusion for easy administration, that we are going to learn. 1 ml of insulin contains 40 unit of insulin. So 1 ml contains 40 unit. How do we prepare the solution? We have to prepare a solution containing 1 ml insulin with 39 ml of normal saline. So 1 ml insulin, that is 40 unit of insulin with 39 ml of normal saline. So in the final solution, what is the total volume of the final solution? 40 ml. What is the total insulin content of the final solution? 40 unit. That means we have essentially prepared a solution with a concentration of 1 unit per ml. That means to a patient whom we want to give insulin at zero point 0.1 unit per kg per hour, we can essentially give him this solution at zero point 0.1 ml per kg per hour, because we have essentially equaled the volume with the unit. 1 ml contains 1 unit, that means zero point 0.1 ml will contain zero point 0.1 unit. So each ml contains 1 unit. So zero point 0.1 unit per kg per hour we can essentially give by zero point 0.1 ml per kg per hour. Similarly, in a patient whom we are starting to give 0.07 unit per kg per hour, we can give him the solution at 0.07 ml per kg per hour, and same goes for 0.05. Those who are starting 0.05 unit per kg per hour, we can give this solution at 0.05 ml per kg per hour, and that will be equal. So how do we prepare that? We have to prepare the solution and load this in this syringe pump. This is an essentially 50 ml syringe pump. In this 50 ml syringe pump, in this 50 ml syringe, we have to load a solution which contains 1 ml of regular insulin with 39 ml of normal saline, so that the concentration of the final solution is 1 unit per ml, and we have to give them at a particular rate. So what rate we give? Let's discuss some examples. For example, we are planning to give insulin at zero point 0.1 unit per kg per hour to a 20 kg child. So how do we give? We take that solution containing 1 unit per ml and give him at zero point 0.1 unit per kg per hour. But that solution 1 unit equal to 1 ml. So zero point 0.1 unit per kg per hour means 0.1 ml per kg per hour. 0.1 ml per kg in a 20 kg child will be 2 ml. So basically we have to give the solution at 2 ml per hour. So that means if that resultant solution is given at 2 ml per hour, the patient will be getting insulin at zero point 0.1 unit per kg per hour. Similarly, let's discuss another example. For example, if we want to give insulin to a patient at 0.05 unit per kg per hour to a 30 kg child. So 0.05 unit per kg per hour means 0.05 ml per kg per hour. 0.05 ml per kg to a 30 kg child means 1.5 ml. So 1.5 ml per hour, if we give that patient, that the patient will be getting insulin at 0.05 unit per kg per hour. What is the role of bicarbonate therapy? Many times it occurs that when a patient of diabetic ketoacidosis comes to us with a pH of 6.8, 6.9, the bicarbonate is 2, 3, something like that, extremely low, and the patient is very sick. There is a tendency in our mind to give or think about giving injection sodium bicarbonate correction, like we give in some other cases of severe metabolic acidosis. But actually, the bicarbonate, sodium bicarbonate, is contraindicated in cases of diabetic ketoacidosis because it is associated with higher mortality and morbidity. Only some limited indications of sodium bicarbonate are there. What are those? If there is life threatening hyperkalemia, very severe hyperkalemia like potassium higher than 8 or 9 with ECG changes, if that is there, we may contemplate giving bicarbonate, because bicarbonate reduces the potassium level, serum potassium level, by causing transcellular shift. Second thing is severe acidosis with impaired myocardial contractility. It has been seen that prolonged severe metabolic acidosis impairs the myocardial contractility. So, if the acidosis persists severely for a long time, the contractility may be impaired, and the fluid that we are giving to the patient may not be effectively pumped by the heart. So, to improve the myocardial contractility caused by a severe persistent metabolic acidosis, we may need to correct the acidosis up to some extent. So, in those cases, we may think about giving injection sodium bicarbonate. So, what is the risk of venous thrombosis? In patients of diabetic ketoacidosis, there is very high risk of thrombosis because all the solutions that we are giving have very high concentration of solutes. So, most commonly, people put a femoral line or sometimes subclavian and internal jugular lines, and they are kept there for a long time. So, there is high risk of femoral thrombosis. So, it is recommended that the femoral lines or any central lines for that matter should be kept for as minimum time as possible. And in particular cases when there is severe or higher chance of developing thromboembolic phenomena, we may need to consider thromboembolic prophylaxis. What are those cases having high risk of thrombosis? Children more than 16 years, young women taking oral contraceptive pills, and very sick patients in whom femoral lines are needing to be kept for a long period of time. Without monitoring, treatment will not be possible in a case of diabetic ketoacidosis. So, patients need to be monitored both by the nursing officers and by the medical personnel, basically doctors. So, what do the nursing officers have to monitor? They have to maintain the fluid balance charts, how much is going in, how much is coming out. They have to do hourly capillary blood glucose. They have to do blood ketones, preferably by a bedside test every 1 to 2 hours. They have to measure the vital parameters as frequently as possible and at least every hourly. And they have to serially measure the consciousness by Glasgow Coma scale or any quantifiable scale for that matter every hourly. And in cases when the consciousness can be very tricky to estimate, for example, in cases with severe metabolic acidosis or cases who are younger than 2 years who cannot describe their symptoms, we may need to monitor the consciousness even more frequently, for example, every half hourly. And the patient has to be weighed at least twice every day because the fluid calculation and all those things, insulin doses depend upon the weight only. Similarly, medical personnel or doctors also have to monitor the patients frequently and monitor the charts 2 hours after starting treatment and then at least 4 hourly. These things have to be monitored. Glucose, blood gas, preferably by a venous blood gas, pH and PCO2, the blood ketones to know about the time of resolution of the ketosis, clinical status and vital parameters, ECG trace to look for the signs of hypokalemia and hyperkalemia, and what is the cumulative fluid balance in the patient. More frequent assessment is required in severe cases like less than 2 years and pH less than 7.1, same as we discussed before. So, what is the concept of pseudo-hyponatremia? So, if we imagine that this is a cell, inside the cell there is some sodium, and outside the cell also there is some sodium, although the sodium is a predominantly extracellular cation. But when the hyperglycemia occurs, this concentration of glucose increases in the extracellular compartment. This glucose cannot cross the cell membrane, so the effectively what happens, the osmolarity of the extracellular compartment is increasing, although the absolute amount of sodium is remaining same inside and outside the cell. The osmolarity outside the cell is increasing. So when osmolarity increases, what happens? Water moves from the lower osmolarity area to the higher osmolarity area. So in this case, the water will move from inside the cell to outside the cell so as to dilute the increased osmolarity. But in that manner, it will also effectively inadvertently dilute the sodium also. That means the total body sodium in this case is remaining constant, or the total sodium content in the serum is remaining constant, but the concentration of serum sodium is decreasing. Why? Because dilution by the water that has shifted from the intracellular to the extracellular compartment so as to normalize the osmolarity difference caused by the hyperglycemia. So actually the sodium content is remaining same, but the concentration is becoming less. This is called pseudo hyponatremia. If we want to discuss or learn about more such abnormalities of sodium, I will give a link of my other video describing the sodium imbalances here. So what effectively happens is when the glucose goes on increasing beyond the normal value, the sodium content remains the same, but the measured sodium concentration becomes less. So for every 100 milligram per deciliter rise in glucose, the sodium concentration measured by biochemical tests comes 1.6 less. That means when it is increasing from 100 to 200, the measured sodium decreases by 1.6, although the actual sodium content is same. Similarly, when it is increasing from 200 to 300, it is becoming 1.6 less further. From 300 to 400 and 400 to 500, the sodium is actually becoming 1.6 times or 1.6 less every time the glucose increases by 100 milligram per deciliter. So suppose the initial glucose concentration was 100 and the initial or actual sodium concentration is 145, but now the glucose concentration has increased to 500 milligram per deciliter. How much will be the measured sodium now? 100, it has increased to 500. That means by 400 it has increased. So for every 100 increase, the measured sodium decreases by 1.6. So for 400 increase, the measured sodium will decrease by 1.6 multiplied by 4, that means 6.4. So when the glucose level is 500, the measured sodium will be 145 minus 6.4, that is 138.6. So what does it imply? The actual sodium concentration is 145, but the measured sodium concentration is coming 138.6 due to the movement of water as we discussed in the previous slide. So this is the concept of pseudo hyponatremia. hyponatremia. Why it is important? Because when we proceed with the treatment of a patient with diabetic ketoacidosis, the glucose starts decreasing. So when the glucose starts decreasing, this value will start on reflecting more and more the actual value. That means with resolution of hyperglycemia, the serum sodium should increase gradually. If the serum sodium is remaining same or decreasing when the hyperglycemia is decreasing, then it is a notorious sign or ominous sign reflecting the development of cerebral edema. So what is the corrected sodium or the actual sodium, so as to say? The measured sodium plus 1.6 multiplied by plasma glucose minus 100 divided by 100. So for every 100 milligram per deciliter rise from the actual value of 100 or the baseline value of 100, this measured sodium is coming 1.6 less than the actual value. That is the concept of corrected sodium. Anion gap, as you know, diabetic ketoacidosis is a condition of high anion gap metabolic acidosis. If there is no clinical improvement, typically 20 to 30 millimole per liter is the normal anion gap or is the anion gap seen in the cases of diabetic ketoacidosis. But if the anion gap increases to more than 35 millimole per liter, it may suggest the coexistence or presence of a lactic acidosis, which is most commonly due to sepsis or poor perfusion. Hyperchloremic metabolic acidosis is commonly seen in diabetic ketoacidosis. What is the cause? Because of administration of large amount of fluids containing chloride, preferential renal excretion of ketones instead of chloride, and the acidifying effect of chloride can mask the resolution of ketoacidosis also. Hypophosphatemia, because a lot of amount of phosphate is lost during diabetic ketoacidosis via the urine due to osmotic diuresis, but routine administration of potassium phosphate or phosphate containing solutions is not recommended. It is only recommended in cases of severe hypophosphatemia which are associated with metabolic encephalopathy, reduced myocardial contractility, myopathy, dysphagia, and paralytic ileus. While administering potassium phosphate or any phosphate salt for that matter, we have to be careful because that phosphate in blood can combine with calcium and can precipitate hypocalcemia. So you are giving treatment to a patient, but the patient is not improving even after 4 to 6 hours of therapy, because if you institute the treatment timely and in a proper manner, there should be some improvement after 4 to 6 hours. At least the patient should start to show some signs of improvement. But if the patient is not improving even after 4 to 6 hours of therapy, you should consider the possibility of a sepsis. You should consider that there might be some errors in the insulin dosing or the fluid calculation. The lines may be blocked or leaking, so that you are giving the fluid but it is not actually reaching the patient, and there may be some excessive urine loss which is leading to the fluid deficit, which is aggravating the ketoacidosis or acidosis in the patient. If the ketone levels do not fall within 6 to 8 hours of therapy, you may consider increasing the insulin dose to beyond the upper limit, that is more than 0.1 unit per kg per hour. So you go on continuing treatment and the hyperglycemia starts resolving. But the prime role of fluid therapy and the insulin therapy is the resolution of ketosis and acidosis. So till the point of time the ketosis and acidosis does not resolve, you have to continue with the insulin infusion, that is the IV insulin. But IV insulin has a known side effect of causing hypoglycemia. So when the glucose level comes beyond a or comes below a particular range, we may have to think about adding some dextrose to the IV fluids so as to prevent hypoglycemia. So it is recommended that when the glucose level falls less than 250 milligram per deciliter, we have to change the correction fluid from normal saline to dextrose with normal saline. How much dextrose? 5% dextrose. Similarly, when the glucose level falls less than 150, we have to think about adding 10% dextrose also. Special considerations. We do not stop insulin infusion while glucose is being infused, because insulin is required to switch off ketone production. One basic fact we need to remember is that the primary goal of insulin infusion and the fluid therapy, mainly the insulin infusion, is to prevent or to cure or to resolve the ketosis or acidosis. So till the point of time there is ketosis or acidosis, we cannot stop the insulin infusion. We have to continue with the insulin infusion even at the minimum rate. But till the point of time the insulin is being given, there is a theoretical risk of hypoglycemia. So we have to continue IV insulin infusion and we have to continue giving some dextrose along with it when the glucose level falls below 250, because if you don't give, there will be a chance of hypoglycemia. So it is told that less than 250 milligram per deciliter when the glucose is there, we have to add 5% dextrose. Less than 150 milligram per deciliter when the glucose is there, we have to add 10% glucose to the IV fluid. But what if the glucose falls even below the lower range? That means hypoglycemia occurs. That means less than 70 milligram per deciliter. We learned that insulin is being given to resolve the ketosis and acidosis. So obviously we cannot stop the insulin temporarily, we can permanently. So we can only stop the insulin temporarily for 1 hour, and because there is hypoglycemia and hypoglycemia is equally risky, we may need to think about giving 1 2 ml per kg 10% dextrose bolus and increase the dextrose concentration of the IV fluid. If we are giving a 10%, maybe make it 12.5 or 15%, something like that. So when the glucose level falls below 250 milligram per deciliter, we have to add 5% dextrose. When the glucose level falls below 150 milligram per deciliter, we have to add 10% dextrose. When the glucose level falls below 70 milligram per deciliter or hypoglycemia occurs, we have to increase the glucose concentration even more. That means 12.5 or 15%, and we have to give a dextrose bolus also, 10% dextrose bolus 2 ml per kg, and we have to hold or stop the insulin infusion temporarily for 1 hour, and after 1 hour we have to again document the normoglycemia and resume the insulin infusion, because that is the thing needed for resolution of acidosis and ketosis. So if acidosis is not correcting even after appropriate therapy, we discussed this already, we have to consider the possibility of insufficient insulin, inadequate fluid resuscitation, fluid calculation errors, coexistent sepsis, presence of hyperchloremic metabolic acidosis, and salicylate or other prescription or recreational drugs which have acidosis as one part of their side effect profile. So insulin management after resolution of ketoacidosis. When the resolution of ketoacidosis is there, obviously the role of IV insulin has been met. So we have to think about the long-term management of the patient. So we have to think about stopping the IV insulin and starting the subcutaneous insulin, which is the long-term management. So what is the recommendation? We have to start subcutaneous insulin at least 30 minutes before stopping the IV insulin. And in patients of CSII, remember we had stopped the CSII, now we have to start or restart the CSII pumps at least 60 minutes before stopping the IV insulin. So basically what we are saying here is the IV insulin is going on as part of management of diabetic ketoacidosis. But when the ketosis and acidosis has resolved, we have to stop the insulin and we have to start the subcutaneous insulin. But we cannot start the subcutaneous insulin after stopping the IV insulin. There must be a 30-minute overlap time, and in case of CSII, there must be a 60-minute overlap time before changing it completely to subcutaneous insulin. And obviously, as the patient has improved, we have to start giving him orally, and so the orally both food and water and everything. Cerebral edema, the most common and notorious cause of death in cases of diabetic ketoacidosis. We have to suspect presence of cerebral edema or possible presence of cerebral edema when the patient develops symptoms such as headache, agitation, irritability, and unexpected decrease in heart rate or increase in blood pressure. Basically, the Cushing's reflex. And we have to, what are the possible clinical features of a patient developing cerebral edema? The GCS will be deteriorating or decreasing. There will be some abnormal breathing pattern. There might be oculomotor palsy, abnormal posturing, and the pupillary inequality or dilatation, basically anisocoria may be there. So when we are suspecting the presence of cerebral edema in a patient, we have to immediately treat it because it has 25% mortality. So how do we treat it? We have two options. Either we can give hypertonic saline, that is 3% saline, or we can give 20% mannitol, that is 20 gram per deciliter mannitol. So the dose of hypertonic saline is 2.5 to 5 ml per kg over 10 to 15 minutes, and the dose of mannitol is 0.5 to 1 gram per kg over 10 to 15 minutes. And as the cerebral edema is due to more fluid accumulation, we have to think about decreasing the IV fluid rates up to half the maintenance rates what we are giving currently. Do not intubate or ventilate until an experienced doctor is available at your bedside, because the intubation and ventilation of a patient suffering from diabetic ketoacidosis with cerebral edema can be cumbersome. When you are intubating or ventilating, at that point of time there might be transient shoot up of the intracranial pressure. So an experienced doctor has to be available at the bedside to perform this procedure, and possibly a rapid sequence intubation may have to be done. Imaging after the patient is stable have to be done. There is no need of immediate imaging when the patient is sick, but after the patient is stable, definitely a neuroimaging has to be done to rule out other possible differences like intracranial hemorrhage or infarction. The effect of mannitol starts after 15 minutes and lasts up to 120 minutes or 2 hours. So, if after giving one dose of mannitol there is no improvement seen within 30 minutes and the patient still continues to have signs of cerebral edema, we have to consider giving second dose of mannitol or choosing an alternate drug like hypotonic saline. What are the other complications of management of diabetic ketoacidosis? We already know hypoglycemia, hypokalemia. Always we have to correct the hypokalemia before discharging the patient because it can be life threatening. Systemic infections, which are usually the precipitating cause of the diabetic ketoacidosis, those are manifested by fever, hypothermia, raised lactate levels, and raised inflammatory markers. We had sent the quantitative CRP before. And as the patient often has low GCS, there might be some aspiration pneumonia. That's why any child who is vomiting and with impaired consciousness, we have to consider the placement of a nasogastric tube so as to prevent the aspiration. Abdominal pain in diabetic ketoacidosis may be due to liver swelling, gastritis, bladder distension, ileus, appendicitis. We have to do the necessary investigations and maybe a point of care ultrasound to point out the cause and manage accordingly. Now let's discuss two case scenarios basing upon what we have learned, and if you can do that, then maybe we have learned this management protocol successfully and we will be able to properly treat the diabetic ketoacidosis patients in the future. So case scenario 1. At 5:30 p.m. to the emergency department, a 11-year-old male weighing 30 kg has presented to you with pain, abdomen, vomiting and fast breathing for one day. There are no signs of shock in this patient. You do the random blood sugar as you will do in any sick child and it comes to be 561 milligram per deciliter. You do an emergency blood gas of venous blood and the pH is 7.15, bicarbonate is 5.6, PCO2 is 14, plasma ketone is 3 plus, serum potassium is 3.9 and serum sodium is 139. So there is no doubt that this is most probably a case of diabetic ketoacidosis and you need to manage it. So let's assume that this is the final diagnosis and this is a case of diabetic ketoacidosis. How do we proceed with the management of the patient? So what was the first step of management if you remember? The first step of management was giving the fluid bolus. Now, how much bolus will be given and over what period of time will be given depended upon the presence or absence of signs of shock. As in this case, there are no signs of shock. So, what do you do? There is no shock, but if you still give a normal saline bolus, how much amount will be given? It will be given at 10 ml per kg, that is 300 ml, and it will be given over 30 minutes because the patient is not in shock. But as the patient does not have shock, this fluid deficit that is corrected now by the bolus has to be subtracted later from the deficit calculation. So you have given a bolus now. Now the time has reached from 5:30 to 6 p.m. Now we will start the maintenance fluid. So what is the maintenance fluid you will be starting? The maintenance fluid requirement will be calculated by combining the deficit requirement and the maintenance total maintenance requirement. So what was the deficit? The deficit calculation depended upon the initial blood pH. So what is the pH? 7.15. 7.15 means this is moderate DKA. Moderate DKA means how much deficit you will assume? You will assume a 5% deficit. So deficit is 5% means 50 ml per kg. So 50 ml multiplied by 30 kg comes to be 1500 ml. But as the patient did not have shock, this initial bolus has to be subtracted. So 1500 ml minus 300 ml comes to be 1200 ml. This deficit always has to be corrected over 48 hours as per the protocol. So 1200 ml over 48 hours means 25 ml per hour. The deficit has to be corrected at 25 ml per hour. Now the maintenance is fairly easy according to the holiday sugar formula. For a 30 kg child, for the first 20 kg it comes to be 1500 ml, and for next 10 kg 20 ml per kg for every kg. That means 20 ml into or 20 ml multiplied by 10 kg, that is 200 ml. So the total maintenance fluid is 1700 ml. Maintenance fluid is always calculated over 24 hours, that is 71 ml per hour. So per hour correction has to run at 71 ml plus 25 ml, that is 96 ml per hour. So the total fluid requirement is 96 ml per hour. So at 6 p.m., you have seen these parameters. Blood glucose is 561, pH is 7.1, bicarbonate is 5.6. These are the parameters. The GCS is 11. So you have to decide on and advise these things. What is the fluid type? What is the fluid rate? What is the insulin rate? And any additional advice if needed. So what is the fluid type? The ideal fluid is normal saline plus 40 millimole per liter of potassium chloride. The fluid rate we calculated just now, it is 96. And as this patient is not having severe decay or adolescent decay, we decide on a initial infusion rate of 0.05 unit per kg per hour, that is essentially 0.05 ml per kg per hour if we prepare the solution as I told. So 1 hour later you again repeat the blood gas and again repeat the RBS and see it is decreasing, all these parameters are improving, GCS is remaining same. So will you change the treatment protocol now? No, the treatment protocol will remain the same, and same goes for the next hour. Now see, after at 9 p.m. also, the expected response is there. That means pH is increasing, bicarbonate is increasing, the sodium is increasing, which is expected. Gradual correction of the pseudohyponatremia as we discussed. The potassium is decreasing as part of the insulin is being given and all those things. The GCS is improving a lot. So will you change anything? There is no change is needed. But see the next point. The glucose is decreasing, the acidosis has slightly deteriorated, obviously the bicarbonate has fallen, the sodium has fallen slightly. So with resolution of hyperglycemia, the sodium should slightly start on increasing so as to reflect more and more the actual sodium value. So when this type of thing happens, the sodium starts falling with resolution of hyperglycemia, you always have to entertain the possibility of development of a cerebral edema, which is due to fluid administration and the original pathology also. So at this point of time, as there is no clinical signs and the GCS is improving and the changes are not that much severe, you have to consider closely observing the cerebral edema. But at this point of time, as per me, there is no treatment change is needed. And the next hour also, the treatment remains the same. Now see what has happened. The glucose has now fallen to 289. The pH is improving, bicarbonate is improving, sodium is increasing, potassium is falling to 3.3. Nothing to worry. GCS is increasing. So the fluid management will remain the same. Now what has happened? The RBS has decreased to 189. But is the acidosis corrected? No, acidosis is not corrected. That means, is insulin infusion still needed or not? That means yes, insulin infusion is still needed, fluid is still needed. The GCS is not completely normal, 13, still it is abnormal. So you have to continue with the insulin infusion. But as the RBS is now less than 250, you have to consider start adding glucose to fluid. So that means from the NS plus KCl, we'll change it to D5NS plus KCl. That means we have added 5% dextrose here to the fluid, and the fluid rate remains the same, the insulin rate remains the same, rest everything remains the same. Now what happens? The glucose has fallen to less than 150. So same thing we discussed. When the glucose falls to less than 150, what do? We add 10% dextrose to the fluid and make it D10NS plus 40 millimole per liter KCl, obviously. And because we are giving KCl, the hypokalemia has not deteriorated, the fluid rate, the insulin rate, everything has to remain the same. At 3 p.m., see what happened. Glucose is well beyond or well below the hypoglycemia limit. That means 61 is the blood glucose. The acidosis is still there. That means even if we decide on stop holding the insulin or stopping the insulin, that will be only temporary. We still need to give that. But as the patient is having hypoglycemia, what do we need to do? We have to continue the fluid, but we have to give a bolus first. D10 bolus at 2 ml per kg. The patient was 30 kg, so we'll give a bolus of 60 ml. Hold the insulin for 1 hour because the patient developed hypoglycemia. After 1 hour, we again do the RBS. It is 136. Because it is less than 150, will make the fluid 1D10NS plus KCl. The fluid rate remains the same. The insulin has been resumed at 0.05 unit per kg per hour. The fluid has to continue. Similarly, when the RBS is 173, that means between 150 to 250, the fluid has to be changed to D5NS plus KCl. You can see the GCS has increased to 14, and when the glucose becomes 222, the acidosis is almost resolved because the pH is now 7.35, the bicarbonate is 16, the CO2 is normalizing, the sodium has increased, the potassium is normal, the GCS is 15 now. So you have to consider continuing the fluid. But at this point of time, as the acidosis has resolved, you have to consider starting the patient on subcutaneous insulin with an overlap period of 30 minutes, depending upon whether the patient can tolerate orally and how much is the consciousness of the patient. So now coming to this case scenario 2, second case scenario. Let's see if we can figure this out. So at 5:45 p.m. to an emergency department, an 8-year-old male weighing 22 kg has come to you with complaints of pain, abdomen, vomiting, and fast breathing for 1 day. The patient has poor peripheral pulses and prolonged capillary refill time. The RBS is 523, venous blood pH is 6.98, bicarbonate is 2.3, sodium carbon dioxide is 9, plasma ketone is 3 plus, serum potassium is 5.6, serum sodium is 124. So there is no doubt that this is a case of diabetic ketoacidosis, also because we are discussing that today. So how do we manage this case? Let's pause this video, and from whatever we have learned and from the case scenario 1, let's think what will be here in this case. So there is no doubt that the patient will be needing a bolus, but how much bolus? Whether this patient had shock? Yes, the patient has shock because the patient has poor peripheral pulses and increased capillary refill time. So as the patient has shock, we have to give a bolus of 10 ml per kg over 15 minutes, and at the end of 15 minutes we have to reassess the patient. So we gave a bolus that is 22 kg means 220 ml over 15 minutes, and as the patient is having shock, this fluid has not need not be subtracted later from the deficit correction. Assuming that after 15 minutes the shock has resolved and the patient is not having any poor peripheral pulses and prolonged capillary refill time, now we have to then start the uh, maintenance fluid or the IV fluid. So what is the total fluid requirement? It is the deficit plus maintenance. How much is the deficit? The deficit calculation depends upon the initial blood pH. So what is the initial blood pH? 6.98. That means severe diabetic ketoacidosis. So how much was the deficit in severe diabetic ketoacidosis? It was 10%. So 10% means how much? 100 ml per kg. 100 ml per 22 kg, that means 2200 ml or 2200 ml. This deficit always has to be corrected over 48 hours, and as the patient was in shock, the bolus need not be subtracted. So this is coming at 46 ml per hour. So the fluid deficit is 46 ml per hour. How much is the maintenance by the Holiday Segal formula? 1500 ml for the initial 20 kg, 40 ml for the next 2 kg. That means 1540 ml over 24 hours. So the fluid coming at 64 ml per hour. So how much is the total fluid requirement? 46 plus 64, that is 110 ml per hour. That is the total fluid requirement of the patient. So similar to what we discussed in the previous case scenario, at 6 p.m. this is the parameter. Blood glucose is 523, pH is 6.9, bicarbonate is 2.3, CO2 is 9, sodium is very low, potassium is slightly high, GCS is 9, other symptoms are nil. So what is the fluid type? The fluid type is obviously normal saline plus potassium chloride, but as the potassium is slightly high, we have to ensure that the patient is passing urine or has recently passed urine before starting the potassium chloride. So the fluid of choice will be NS plus potassium chloride. The fluid rate will be 110 ml per hour as we discussed before. And as the patient has severe DKA, it is important to start the insulin at a higher rate, that is 0.1 unit per kg per hour. So next hour you do, and the glucose is falling, the pH is slightly improving, bicarbonate improving, PCO2 improving, serum sodium has fallen slightly 122. With resolution of hyperglycemia, there should be increase in sodium, not decreasing. Potassium is normal now, GCS is same. You have to consider giving the fluid while closely monitoring for the possible development of cerebral edema because the sodium has decreased a bit. See what happens in the next hour. The glucose is falling more, acidosis is slightly improving, but the serum sodium is falling even more, 118. From 124 it has come to 118 over 2 hours, but the glucose is decreasing. That means the sodium should have increased by now, but it is decreasing. That means we have to consider the possibility of development of cerebral edema, but the GCS has not deteriorated that much, and there are no other symptoms of cerebral edema present also. What we can do here, we have to consider giving the same fluid, but the rate has to be decreased. We can decrease it further also. From 110 we have made it 105 because of our clinical judgment, but we can decrease it up to 55 also, that is half the maintenance fluid. And we have to closely monitor for other signs of cerebral edema, because at any point of time if cerebral edema happens, we have to give mannitol or hypertonic saline. See what happens in the next hour. The glucose is decreasing, acidosis improving, and now the sodium is increasing slightly than before. The potassium has fallen expected with the treatment. So we'll consider same treatment, NS plus KCl at 110. Insulin is 0.1 unit per kg per hour. What happens at 10 p.m.? The glucose is decreasing, acidosis improving, sodium is increasing, so everything is fine. Even the GCS is increasing. That means our treatment is going correctly. We have to consider the same treatment continue. Now the glucose is 256. The pH is slowly improving. The sodium is increasing. The potassium is in the normal range. GCS has improved from 9 to 10. So you have to continue the same. But when the glucose falls to 224, that means less than 250. Whether the acidosis has resolved? No, the acidosis is still there. That means insulin has to be continued. If insulin has to be continued in presence of RBS less than 250, what do? We change the fluid from normal saline to D5 normal saline, or 5% dextrose has to be added. Everything else remains the same because it is signs of improvement. At 1 p.m. or 1 a.m. sorry, the RBS has decreased to 126. The rest everything looks expected as per the treatment plan. But as the RBS is between 150 to 250, or rather less than 150, we have to increase the glucose concentration from 5% to 10%. The fluid rate and the insulin rate has to remain the same because the acidosis is still there. What happens at 2 a.m.? The glucose is 76. It is normal, not below 70. That means we don't have to give the bolus now, but we have to consider giving 10% dextrose continue. Now what happens? The glucose is rising to 110. The pH is improving. The bicarbonate is improving. The sodium is increasing. Potassium is normal. GCS is increasing 12. That means same treatment has to be continued. At 4 a.m. the same treatment has to be continued because the GCS has increased further from 12 to 13. Same treatment has to be continued. The glucose is now between 150 to 250. So the 5% 10% dextrose has to be changed to 5% dextrose. And as the patient is showing signs of improvement, as you can see, the insulin rate we have started titrating from 0.1 to 0.09 to 0.08 to 0.07 unit per kg per hour. It is glucose is now 114. The acidosis is now completely resolved. Bicarbonate is now almost normal. GCS is 14 now. Everything else looks normal. So we have titrated the insulin to 0.06, and hopefully by the end of the treatment, the glucose, the pH, the bicarbonate, the sodium, the potassium, everything is normal. But see, the potassium is slightly low because of the complication of the treatment. So we'll be titrating the insulin to the minimum dose at 0.05 unit per kg per hour. We have to give the fluid until the complete resolution of the symptoms, and we have to start considering giving the subcutaneous insulin with an overlap period of 30 minutes. But as the potassium is 2.9, we have to consider giving oral potassium chloride so as to correct before discharging the patient, because hypokalemia is one of the causes of death in diabetic ketoacidosis. So I hope you all learned today. We all learned today, and after few days, I'll be again posting another video describing the ISPAD guidelines of diabetic ketoacidosis management. And after that, we'll compare the BSPD and ISPAD and the older guidelines, and to see which protocol we need to follow. If you like this video, press like, share with your friends, and subscribe to the channel. Thank you.